In chapter 3, we are looking at how drugs are classified and different kind of categories of them. So our learning objectives, there are 3 ways of naming drugs that we'll go through, some different classifications for them, and then essentially what allows them to be classified that way. Also looking at things that need to go on the prescription, medication orders, standing orders, these are common in hospital settings, the different drug schedules, and again, that classification system, as well as what alternative drugs are. So the 3 names that we have for drugs, and this is just kind of the rules that we use for naming these as they're discovered. So the first one is the chemical name, and this is typically then the name that you won't be able to pronounce. It has a lot of the chemistry in it. I did pick an easier one, acetyl salicylic acid, just as an example. So this is going to give us an idea about the chemistry behind it, hence the name chemical name. Usually has a lot of numbers and things like that, that to a chemist means a lot. To most of us, doesn't mean much. So the exact formula of the molecular structure, again, typically this is not going to be on the label. Then we have the generic name. So in this case, this is aspirin. So this is preferred in the healthcare because there are lots of different brand names out there that are hard to keep up with, but everybody knows what aspirin is, regardless of kind of the brand that goes along with it. And that name is going to be on the label, and it is not capitalized as a way of identifying it. Then the proprietary, or again, the brand name, this is going to have a trademark. Here, like we see, here we go, have our trademark on there. Indicates that's kind of your first indicator that this is going to be the brand name or the proprietary name. And so this is assigned by the manufacturer. So again, there's Bayer and niacin. They're both aspirin. So that's why in the hospital setting, we just go with a generic name. So you're not trying to remember all these trade names. And it will be on the label and is capitalized. So again, that trademark symbol and the capitalization help you know that it would be the proprietary name. And then just a few other examples that are listed here. So again, brand name, proprietary, same thing. So again, Demerol, thinking about some of our pain meds. So Demerol, again, that trademark. And then the generic name is listed here. So Mepridine hydrochloride. And then we see again this chemical name, these crazy numbers and letters and all this stuff that tells us about the chemistry behind it. So how drugs are classified. So there are 4 main classifications. So they're either over the counter, these we're all familiar with, OTCs, prescription drugs, and that prescription can either be a written prescription, which is pretty rare anymore with electronic prescriptions being used, but also there are medication orders in a hospital. We'll talk about 2 standing orders and verbal orders. And these are things, they're still talking about drugs that have to have a prescription to be used, but that's not what that prescription looks like, isn't always the same. It's not like a tablet or even an electronic. There are some different variations that we'll go over. And we also have controlled substances, which are prescription. So those kind of go together because all controlled substances, if they are legal, then a prescription would be required for them, but they do get their own classification. And then our alternative or complementary classification. So first of all, the OTCs. So no prescription is required for these. Again, we can get them over the counter. So they can be purchased directly by the consumer. We don't need to go to the doctor or have anybody to prescribe them. We can just get them. Now, there are lots of criteria in order for a drug to be classified as over the counter. A couple main ones: minimal risk and maximum benefit. So there's not a lot of risk to the patient. That doesn't mean there isn't any. It just means compared to those prescription ones, kind of minimal risk. low potential for abuse. Again, doesn't say no potential for abuse or misuse, but very limited. Treats common conditions that don't really require a diagnosis. So again, a common cold, we get those all the time. You know, you can feel them coming on. You don't need to go to a doctor for them to say, oh, you have the cold. You just know that one. That's easy to recognize, compared to something very hard to diagnose, again, like cancer. You don't just know, unfortunately, that would help with the diagnosis that you have that. You're not, you know, it's not something easily diagnosed. The label has to have a lot of information on it that can be given in a user-friendly format. So it has to be easy to administer, something that it can be easy to talk about kind of in common terms. And it also doesn't need to be monitored by a physician. So some drugs may not have much potential for abuse. We might need them, but they are something that has to be monitored. They can, like, blood work has to be done or things like that so that we can determine the reaction to them. All right, now prescription drugs, these are going to obviously require some type of prescription. So there's a lot of outlining of the care of the patient that is needed. That's what they're prescribing, is how to use them and what to take. So this is given by a physician or other licensed healthcare professional. So like a nurse practitioner is an example, not a physician, but does have the ability to prescribe things, or, you know, like an optometrist there. So it's not just a physician, but again, they have to be licensed. And this can pertain to various types of therapy and treatment that's prescribed. So it's not even just drugs. Of course, we're covering it in pharmacology, but physical therapy could be prescribed. So that's a prescription as well. So we're mainly focusing on the drug aspect though. So these are represented by, you know, RX indicates that it's a prescription drug. And those written prescriptions are typically given to the patient. Again, we are really moving away from that. I don't remember the last time that I went to the doctor, they actually gave me a physical copy of it. Typically, they just electronically send it to the pharmacist. Now, what information has to be on that form? So the prescribers, and this is on the prescription, not the drug itself. So on the prescription that's being provided to the pharmacy, the prescriber's name, their address and phone number. Sometimes it might have their license number or the DEA number if it's a narcotic. The patient's information, so name, address, date of birth, the date that it's being prescribed, all the instructions for the patient. So is it being, you know, has to be taken with food or early in the morning or late at night, those types of things. Number of refills that are allowed, if any, and then the signature. And again, that can be an electronic signature. And then also the brand or generic substitutions if allowed. And so that needs to be indicated. Here's where we get into tricky things with insurance. Insurance is always only going to want to cover the generic, but sometimes physicians don't like the generic and they really want you to go with the brand. So you need to have that conversation. So if you are talking about prescriptions, you know, make sure you have that discussion because insurance becomes an issue. Now, prescriptions in the hospital may look a little bit different. So there are a couple types of medication orders. So again, even not just the electronic prescription that can be used, but this is whenever the patient is admitted. Again, it can be handwritten or computer generated, but it pertains to all aspects of the patient's care. So this medication order already has everything. So not only the prescriptions that they need, but also are they allowed to eat? Are they restricted to like a liquid diet? You know, things like that. Every part of that is referred to or part of that medication order. And then the same information though is on a written prescription goes into this medication order as well. And it's still filled by the pharmacist and administered by the qualified personnel. So whether it's a nurse or whoever, anesthesiologist, whoever is actually giving that medication. Now, the medication orders in surgery, these are typically about administering the anesthesia. They're administered either by them, the circulator, or the surgeon. surgical tech not typically doing that, but often the surg tech plays the role of circulator. So that's why it's important to know this. So then it can also go to some other team members in different situations. Now, standing orders, slightly different. So these are pre-established for patients with a specific condition. So for example, if you have somebody who's having knee replacement, doesn't matter who that patient is, there's a standing order. Anybody with a knee replacement, we're doing X, Y, and Z. So it's not necessarily just for that patient, but a standing order is pre-established based on the condition. So this is kind of the standard procedure that's in force unless otherwise indicated. So the staff can immediately begin initiating that treatment. They do not have to contact the physician. So again, they're coming in with this specific disorder or condition. All of those medications, all of that treatment can start immediately without waiting for the physician. Just speeds that whole thing up. Now, the surgeon preference card is a way of documenting that standing order. So this includes all the pertinent information for the surgical procedure, and this can include the instrumentation. So again, as you're getting the instruments ready for a surgery, the surgeon preference card would have like what type of sutures, the needles for the syringes, that type of thing, all the equipment that they would need. So that falls under the surgeon preference card. Right, verbal orders, again, we mentioned this already, but verbal orders are issued by the physician when it's not convenient to write them down. So, prime example, during surgery, you can't write those down, fill out an electronic prescription, etc. So, verbal orders are acceptable. However, if you do not understand, ask for clarification. Do not just be like, oh, I'm pretty sure that's what he said. No. Make sure you understand what that physician said before you would do it. And then the updated order is recorded. So again, that pre-established thing is already kind of uploaded for you, helps with all the documentation. But then anything different or anything added would also need documented. So some of the terminology here that gets used in some of our common abbreviations. So table 3.2 and 3.3 are great tables to look at in your text. I just want to highlight a few of the abbreviations from those tables. You don't have to know all of them, but I do want to highlight a few that you will be responsible for. So the first one's CC, so that cubic centimeter. So we mentioned this whenever we were talking about the math part in chapter 2. So a CC is that cubic centimeter, but it's also equivalent to 1 milliliter. Okay, so make sure you know that one. IM, so some of our injections. So IM stands for intramuscular. So that's how that's going to be given. IV, intravenous, most of us know that one already. PC, so post-citium, I don't care that you know what the abbreviation stands for, but know what the abbreviation, what it really means. So PC means after meals. So it's important whenever talking to a patient or understanding that prescription. Sometimes this is part of the instruction. So that's a medication that has to be given after their meals. So it's PC. Here, so per, PER, but it's pronounced per, not the actual letters. So per just means how. So per IV, per injection, is talking about how it's given or by through, like which means. PO is by mouth. So we have our different injections like IV and IM. If it's given orally, PO is the abbreviation for that. PRN is as needed. So a lot of times after surgery, pain medication is prescribed as needed. So they have the prescription there, so you don't have to go get the doctor to prescribe that, but that's not given on a regular basis, just if the patient needs it. And then SQ or SC is for subcutaneous. That's one of our other main injections. So IV, intravenous, IM, intramuscular, or subcute, which is SQ or SC. And then our last one is STAT, and you've probably heard this one on TV shows, so most of us know this one. STAT just means immediately, so we're giving that drug right away. All right, now some of the controlled substances that are being used, these are narcotics, so same thing, controlled substance, narcotic, interchangeable words that we are using. So they are classified into those 5 categories. Here's one of the main reasons we need to know those Roman numerals. Are also called drug schedules. Again, same thing. So the first one, so category or schedule 1 means that there's no currently accepted medical use. And the main reason behind that is that it's highly addictive. Again, currently marijuana by the DEA anyways is classified as Schedule 1. Lots of debate about that. Besides that, though, again, lots of things fall under the Schedule 1. It means they're out there, they're very addictive. We're not prescribing those. Schedule 2, there isn't approved medical use, but there's still that high potential. For example, fentanyl, very effective pain medication or narcotic, however, lots of potential for abuse, so it is heavily regulated. Now, as we go up our numbers, so as we move toward 5, it's just going to become less addictive. So again, all of these are going to have medical use, and these are just going to have a less potential for abuse than Schedule 2. Schedule 4 has less potential for abuse than Schedule 3, and then 5 has less potential of abuse than 4. Now, there's not like a set scale, so again, the DEA is who sets this, so they try to look at data that looks at potency and overdoses and percentage for abuse. So, they try to quantify this as much as possible to separate these into these different schedules. But again, the main point is that they are all addictive, so they need to be handled with a little bit more regulation. So all of these narcotics have different rules or additional rules for their prescriptions. So drugs are classified also, so we have those categories. So again, we have their over-the-counter, prescription, alternative we're coming up to, or those narcotics or controlled substances. But they also get classified based on their principal action. And this is mainly determined by the chemicals that are used. So like barbiturates, NSAIDs, for example, like aspirin and some of those. So this is putting them into their principal action. Opiates or opioids, for example, that's a principal action. So kind of all of the drugs, they have a very similar chemistry for how they work. The body system affected, that makes sense. So is it working on the central nervous system? Is it a cardiovascular drug? That type of thing. Is the body system affected? The physiological action. So it's working on the CNS, on the central nervous system. What's it doing? What action does it have on that? Is it a depressant? Is it a stimulant? Are we increasing blood pressure? Are we decreasing blood pressure? So the effect it's having on that body system is called the physiological action. And then our last one is the therapeutic action. And this is why it would be given or provided. So it's a pain reliever. It's an anti-inflammatory drug. It's a high blood pressure medication. It is anti-convulsive. It is anti-epileptic. So that's the therapeutic action. That's the reason that it's being described, the action we want it to do. Okay, so the one that typically gives us the most trouble here is that principal action and therapeutic action. So again, therapeutic, think about therapy, it's what it's being used for, the treatment it's providing. The principal action is more that chemistry, that classification that puts it into a group, kind of categorizes them based on their chemistry. Our last category are the alternative and complementary medications. So these are going to have the least amount of regulation. So vitamins, for example, they do not have to be FDA approved. So there's very little regulation in that manufacturing process. So buyer beware, very much so with these. So they can be very beneficial, or they can also have the ability to be dangerous depending on the situation. Sometimes they just don't have an effect and you're just really wasting your money. However, some of them do offer lots of benefits. So the patient should really be questioned though about the use, because a lot of people don't think about these, like, oh, I take vitamin D, or I take a B6 vitamin, or things like that, and they don't typically disclose that. So again, as you're taking inpatient medication or checking in, make sure you confirm, like anything else, like over the counter or like vitamins, anything, just again, make sure that everything is being disclosed, because there can be those drug interactions. So again, herbal medicines, like ginkgo biloba was pretty popular a while ago. It's kind of fading now, but like creatine and like muscle builders and things like that. So those are still drugs that need to be disclosed, and everyone needs to know what they're taking, because it could interact with other medications or cause some potential for harm during surgery or anesthesia. Again, it's just always good to know for sure what the patient is taking.